Okay, well, there is our cue to get started on there. Um, Leo and I were talking earlier today about closed captioning and the debate of whether you're young and you want that, or you're old and you don't, or you do. I don't love it, but if you want closed captioning on, down at the very bottom, there is the option to choose closed captioning, and you can turn that on. We're thrilled to have you for our IDRPP, the Institute for Disability Research Policy and Practice Autism Echo. We're thrilled for our session today. As you noticed, we are recording that. We use that for educational and quality improvement. You can always go back and review the recordings as well as share the recordings. But if you do not wish to be recorded, then you can go ahead and hit that leave button. I want to give a big shout out and thank you to the children with special health care needs at the Department of Health and Human Services for providing funding for this project. I love this project to just increase that awareness around autism. We have a great year of sessions ahead of us, so I'm thrilled to continue to offer that. If you've never joined an ECHO session, we're thrilled to have you here today for your first one. The components of an ECHO session is that we always have a subject matter expert, and we are lucky to have Amanda from the ADDM and URAD network, and she will go over those acronyms as well as giving us some of that information. We also always have a case presentation and then a time to have small breakout rooms to discuss that. And that's where that professional networking comes in. We love the interactive community. So if you have questions, comments, concerns, put those into chat, and Colin Kingsbury, one of our amazing hub members, will make sure that that is answered and we get that information to you. We also love case studies. We're not out here doing these jobs independently, and sometimes it feels like it. So if you ever have a case that you want to get information from all of these amazing people on the call, please reach out to us and we will get you on the schedule. When we are doing these echoes, please remember some of the session etiquette. Respect the presenter. So either use chat or raise your hand to ask the questions or contribute. Remember to keep those questions concise and brief and on topic. I know that sometimes some of the discussions we talk about are sensitive and we get passionate about those. But again, make sure that we are keeping those on target. Always take a minute and introduce yourself and organization before asking that question. Again, that just helps us know where everybody's from and be able to do some follow-ups if I want to learn more from you. And we always encourage you to turn your camera on during the session. Just again helps us connect on this virtual platform that we are thrown into. We do also talk about some sensitive topics. So if you have any questions about protecting individual privacy, please reach out to one of the amazing hub members we have for this session. They all have an asterisk and the background behind them so that you're easy to find them in chat. Renaming your profile and raising your hand. Again, if you have any questions about that, please reach out to Leo or Tori. They'll be able to answer those for you. In order to get a credit of attendance, we do ask that you complete the survey. Throughout today's session, Tori will be dropping that into chat, as well as with our follow-up email that then we email out the credit for attendance certificate. We store everything on our Canvas page. And with all of the case recommendations are also stored on Canvas. So maybe you have a case and you don't really want to present it, but some of the ideas that are shared during your breakout session, you can always go back and download all of the recommendations. Everybody on this call comes up with some great resources and ideas that are wonderful to use for all of the families and individuals that we work with. So if you ever want to go back and look at those, please reach out to us and we'll get you access to our Canvas page. Another plug for that case study. Case studies are a great way to learn from each other, and they're a great way to just continue to talk about some of the things that we all work with on our day jobs. If you are interested in presenting a case, please just reach out to autismecho@aggies.usu.edu and we will get you set up for that on the schedule. We do have social media where we share information, we share things about upcoming sessions, resources that are shared with us. So if you've not taken a minute, you can go ahead and follow us on social media. And then I'm going to, again, stop sharing and just thank you all for being here and turn the time over to Amanda, who's going to be our subject matter expert today.
Great. Hi, everyone. Thanks, Janelle. Let's see. Share my presentation. Okay. Are we good? We can see my presentation.
So go ahead and flip it again. We're seeing your notes. So go to your display setting.
How's that?
It hasn't switched yet.
Okay, let me stop that. I had two options to share the PowerPoint, so I must have chosen the wrong one. Let's try.
There. Is that perfect?
Okay. Excellent. Well, it's great to be with you all today. My name is Amanda Bakian. I'm an associate professor of psychiatry at the University of Utah and the Husband Mental Health Institute. I am an environmental and psychiatric epidemiologist and biostatistician by training. I am the director of the Utah Registry of Autism and Developmental Disabilities and principal investigator of the Utah Autism and Developmental Disabilities Monitoring Network. So we love acronyms. So I will be referring to the Utah Registry of Autism and Developmental Disabilities as URAD throughout this talk, and the Utah Autism and Developmental Disabilities Monitoring Project as Utah ADDM through this talk. It's great to see. I see lots of the team here from URAD and Utah ADDM, so glad they can be here today. I always like for these presentations to be more like discussions. So if you have questions, please put them in the chat box and maybe Colin will interrupt me and we can address them as we go. Okay, otherwise, yeah, let's get going. My plan is to talk maybe about 45 minutes and would love for also some discussion afterwards as well. So I don't have any disclaimers to share with you today. Okay, here's what we'll talk about. We'll first talk about the progression of autism diagnosis over the past 70 years or so, just because it's really important to understand how the definition of autism has changed, the diagnosis has changed, so we can understand where we are now in terms of the prevalence of autism. Let you know a bit about the Utah Registry of Autism and Developmental Disabilities, and then the CDC's Autism and Developmental Disabilities Monitoring Network, that we have a local site here in Utah that participates in that network. Talk about that work, and then we'll discuss findings on the prevalence of autism in 4 and 8-year-old children, both in the network and for Utah specifically, because I think some of you are coming from outside of Utah as well. So we'll take a broad picture there. And then we'll talk about a study that we've done here locally on looking at what we're seeing in terms of early autism screening in our 4-year-olds specifically, and what referral practices are happening following a screen. Okay. So we will start with the very first definition of autism. and identification of autism, which really happened in the 1940s. Kind of at the same time by Leo Kanner here in the United States, and then Hans Asperger in Germany, or Austria, excuse me. So Leo Kanner's definition is probably really what we could think of as classic autism. And while it was recorded and recognized, he recognized in about 11 children, and that was initially how it was done. It took quite a few years before, it really evolved from there. Also to note that Leo Kanner actually established the first child psychiatry clinic in the U.S. At Johns Hopkins. So I think he's just notable for some of his work in children along those lines. So from there, the first time autism was described in our diagnostic and statistical manual of mental health conditions was in the DSM-2, and it was really captured under a childhood schizophrenia diagnosis and wasn't separated out from child schizophrenia. And that separation didn't happen until 1980 with the DSM-3, where autism was listed and distinguished from childhood schizophrenia in a fairly narrow definition at the time. We had a revision of DSM-3 where a checklist of criteria for autism was added in 1987. And then in 1994, with the DSM-4, we had autism separated into 5 unique diagnoses. And I think this is when autism really started to become recognized, and awareness of autism really started, a flag was established from that point on. And we saw with the DSM-4 a very broad umbrella definition of autism that included these 5 specific diagnoses that then corresponded with DSM diagnoses. So then, we did have a revision in the year 2000, and now we are working under an autism diagnosis, one single autism diagnosis that was introduced in DSM-5 in 2013. That really focuses on the social communication and interaction difficulties related to autism, and then also the repetitive and restricted pattern of behaviors and activities or interests, and that includes also the sensory behavior piece. So we have one umbrella diagnosis for autism currently. And we really have seen big changes in our identification of children with autism with these different definitions. And especially under the DSM-4, where when we look at how changes in prevalence of autism, we saw a real big increase in the prevalence under DSM-4 that's continued under DSM-5. All right. So what do we know about the causes of autism? We could do many just individual talks on this, so I will only cover this very briefly. Autism is an incredibly heterogeneous condition. We do know that it clusters in families. So if we have a index sibling with autism, there's about up to a 20% probability that another sibling will have be identified with autism as well within a family. This has been a very consistent statistic over the years, but there is a known etiology, genetic cause for about 10% of autism, of individuals with autism, and that, such as Fragile X syndrome. And that, again, that percentage has not changed. And for the most part, the exact etiology for autism is unknown. We know, given that it's a highly heritable condition, that genetics play a really large role in autism, and then the environment does as well. But in terms of the specific gene by environment interactions, many of those are not well understood yet. All right. So why do we track autism prevalence in a community? The prevalence is important for a number of reasons. First, it is to establish what are the needs of the community. What is the population of autistic individuals in the community, so that we understand potentially what services that community might need. We also it's really important to understand characteristics about autistic individuals once they've been identified. Who is accessing the services that are needed? counting individuals with autism in a community gives us a sense of where maybe awareness about autism is lacking, so we can focus some of our attention on improving awareness in for certain populations and certain groups of people. And then we're really, now at this point in the work that we're doing in terms of epidemiology of autism, we're interested in understanding what are characteristics associated with autism. As many of you are very aware, autism rarely occurs on its own and is usually accompanied by other co-occurring conditions. And so understanding the full landscape of what autism looks like in a community is really important to provide the services that are needed. Okay. Just very briefly, in terms of what do we mean by even what is the prevalence of autism? It is a measure of the number of autistic individuals out of a total population of interest. And so we will talk a lot today about the prevalence of autism among 8-year-old children. So that is a lot of the work that the CDC's ADDM network has been focused on. Has been identifying autism in 8-year-old children. So in order to get that number, we have to start with the population of 8-year-old children, identify those who have autism, and then we look at the ratio of the number of 8-year-old children with autism out of that entire population. Okay, so stepping back a bit, Utah has actually been conducting work in the identification of autism, epidemiology of autism for multiple decades now. We participate in one of the first population-based autism studies in the US. This was done in the mid-1980s. It was a collaboration between UCLA, the University of California at Los Angeles, and the University of Utah. And this is kind of looking in hindsight, an impressive study. So this was called the UCLA University of Utah Epidemiologic Survey of Autism. The goal was to do population-wide identification of autism among all youth and young adults less than 25 years of age. At that point, Utah's population was less than 1.5 million individuals, so they did population-wide work in the state. They used multiple levels of identification. They would review medical records from individuals with a previous autism diagnosis. They would also receive referrals from family members with potential concern of a family member with autism, receive school and health referrals as well, and then they would do active case findings in the field. And they used a retrospective record review process under DSM-3 criteria to identify youth and young adults with autism. So some of their initial findings from that time, again, this was under DSM-3, so a pretty narrow definition of autism, but the prevalence was estimated, again, among youth and adolescents less than 25 years of age, a prevalence of 4 per 10,000 individuals. They looked at the prevalence of co-occurring intellectual disability among autistic youth and adolescents and found that 66% of autistic youth and adolescents had co-occurring intellectual disability. They found a male to female ratio of 3.7 to 1. That is a ratio that's really stayed pretty firm in Utah. And then again, they found that 10% of their autism cases clustered in families. That has broadened since the definition of autism has broadened. Then this statistic of finding that 10% of cases were associated with a rare genetic disorder has really helped, but they found a 10% rate associated with Fragile X syndrome, Rett syndrome, and so forth. Okay, so since then, that work really encouraged these more longer-term establishment of ongoing epidemiologic work in Utah. This was because of stakeholder interest in Utah. We also work with, at that point, the Department of Health, the Utah Registry of Autism, and the University of Utah. So those three groups came together to establish the Utah Registry of Autism and Developmental Disabilities, or URAD, in 2003. And at that time, there was public health code passed that made autism, intellectual disability, and related developmental disabilities reportable conditions in Utah. So we have state law that supports this work. URAD is a program within the Bureau of Children with Special Health Care Needs at the Department of Health and Human Services currently. So we are a partnership between Department of Health and Human Services and the University of Utah Department of Psychiatry. We have also required long-term and been lucky to have long-term collaboration with the Utah State Board of Education. So URAD is a public health population-wide surveillance system for autism and associated developmental disabilities. How URAD data is used for many purposes. We are used to inform public policy decisions. So the data that URAD produces has been used to justify the covering of autism services by health insurance. So the health insurance mandate that was passed in 2014 used URAD data in order to be passed. So we're really proud of that. URAD data is used to plan for autism and developmental disabilities related services. So the Adult Autism Center through the Pingree Center and Valley Behavioral Health was also URAD data was used to inform establishing those services. URAD data is used to improve community awareness of autism and developmental disabilities by knowing how prevalence is varied among different community groups. We've been able to focus awareness activities in different groups. And then we'll talk about, again, what we found in terms of autism screening shortly. So the information we use is aimed to increase community access and awareness of autism and developmental screening and screening tools. There has been a long goal and effort to lower the age at which a child is first identified with autism or developmental disability. So we track what is the median age at which a child is first identified, and has that changed over time? And then we do a lot of work on the epidemiology of autism and the causes of and outcomes related to autism, which we won't talk about today, but I'm happy to present again and talk about that. So switching modes to the Autism and Developmental Disabilities Monitoring Network. While URAD is tasked with doing statewide identification of autism and statewide tracking of autism prevalence, we are part of the CDC's Autism and Developmental Disabilities Monitoring Network, which funds us to do focused identification of autism in a part of Utah. So the ADDM network was established in the year 2000 and does cross-sectional identification of autism. That's so every 2 years in different communities throughout the United States. The specific communities that participate in ADDM have changed typically every 4 years. And Utah has participated in the ADDM network in study year 2002, 2008, 2010, 2012, 2018, 2020, 2022, and now we're currently in the middle of study year 2024. So this is the map of the sites around the U.S. that are participating in the ADDM network currently. So you can see we represent, we have coverage throughout the U.S. And often I think that the ADDM network methodology for identifying children with autism and estimating autism prevalence is now the gold standard approach in the U.S., given that while it would be ideal to do population identification with actual assessment, that is fairly cost prohibitive. So given that, the ADDM network is become the gold standard. However, the study, I just like to stress that while often our estimates are used to represent what the prevalence of autism is in the US, it is not designed to do that. It reflects what the prevalence is among certain age groups in these locations. A different study design would be required for ADDM data to reflect national autism prevalence. So I just want to be clear about that. But so you can see from the map, though, what parts of the country participate. And then for the first time in study year 2022 and 2024, Puerto Rico has participated. So now we have included U.S. sites that are not part of the continental U.S. Okay. So the ADDM network itself has goals that are pretty consistent with URAD, but also, somewhat unique. The goals of the ADDM network include to obtain as complete a count as possible of the number of 8 and 4-year-old children with autism in each ADDM network area, and then to look at changes in that count over time. We are also interested in acquiring information about early identification of children with autism, including the ages of an evaluation diagnosis. We now have, in addition to looking at the prevalence of autism characteristics in 4 and 8-year-olds, we have a 16-year-old component. So we now describe health and service needs of 16-year-olds with autism, and that's work that Utah participates in. We are also collecting information on the characteristics of children with autism, including sex. So again, looking at male to female ratio, race, ethnicity, and co-occurring intellectual ability. We are interested in looking at whether if autism is more common in some groups of children, boys versus girls, and those have changed over time. And then we're also acquiring information on the impact of autism and related conditions on children, families, and communities in the United States. Okay, so currently the surveillance area for Utah ADDM in Utah is a 3-county surveillance area: Tooele, Salt Lake, and Davis counties. This has changed over time. And in 2002, we started in Salt Lake, Davis, and Utah counties. In 2008, we were a smaller area in 1 county in Utah. And then since 2010, we've been this 3-county surveillance area. Our age groups have expanded over time as well. The ADDM network initially focused on tracking autism in 8-year-olds specifically, because the idea at the time was that the prevalence of autism peaked by age 8. We actually have a lot of reason now to think that's not the case, and the prevalence of autism actually continues to increase into adolescence, probably through age 16. But that was the initial thought and why age 8 was the focus. Then in 2010, ADDM expanded to also include 4-year-olds, so we could get more information about early identification. And then in 2018, the project expanded to do some follow-up work in 16-year-olds. So, currently in study year 2024, we identify autism in 4, 8, and 16-year-olds. We estimate prevalence in 4 and 8-year-olds, not 16-year-olds. And we have a new piece where we are identifying cerebral palsy in 4 and 8-year-olds. We won't talk about that data today. All right. The ADDM network has changed its methods over time. Until study year 2018, we used a method where we would abstract information out of medical and health records of any child we suspected to have autism. We'd put information related to autism behaviors into a composite record, and that composite record would be reviewed by a clinician reviewer who would look for specific mentions of autism-related behaviors, associate them with specific DSM 4 and then 5 criteria related to autism. And if a child met that criteria, then the clinician reviewer would confirm autism in that child, in that 8-year-old. Since 2018, we've actually switched modes. That was a very thorough and intensive process. Now we've come and that we've validated that the community is excellent at accurately identifying children with autism. So instead of doing a clinician review of information in medical and education records, we will review records and abstract information from children who have either a health diagnosis of autism or a special education eligibility of autism. So if a child has a community identification of autism, we review those records, abstract information, so we get information on characteristics of children. But that is our group of children with autism, if they have a community identification of autism, either through an ICD-9 or 10 code, a special education eligibility code, or a mention of an autism diagnosis in a record. And then once the child's been identified with autism, we link their information to their birth certificates, and then also information from American Community Survey, which gives us information about neighborhood level socioeconomic status indicators. Okay, so I just briefly mentioned how we are now currently identifying autism in 4 and 8-year-olds. So in brief, we rely on a written autism diagnosis by a qualified provider, a special education classification of autism, or an ASD ICD code. And then for 4-year-olds only, we also have another classification, which is if a 4-year-old is suspected to have autism. So the child doesn't have anything on the left side of this table, but there is an indication from a qualified provider that they suspect the child is having autism. So we will capture that information as well. And then we are also identifying co-occurring intellectual disability in autistic children, which is based on the presence of an IQ score less than or equal to 70 on a most recent test, or again, a statement from a qualified provider that indicates intellectual disability in a developmental evaluation. All right, besides prevalence, we also measure cumulative incidence, which is a measure of how the rate of increase in autism identification in the community. So it really measures the addition of new cases of autism over a given period of time. And that gives us some information about early identification and if we've seen changes in early identification over time. So I will be presenting both prevalence estimates as well as cumulative incidence estimates. So let's jump into some information about autism prevalence among 8-year-olds in study 2022. This is our most recently published data information that was published last April by the CDC. So this is the prevalence of 8-year-old children since the ADDM network was first established in the year 2000 through 2022. So in the year 2000, 1 in 158-year-old children was identified in autism in participating ADDM network communities. As of 2022, 1 in 31 8-year-old children has been identified with autism. So yeah, we see a sort of stepward, upward increase in the prevalence of autism over time. Couple of things that I just highlight here is the introduction of DSM-5 in 2013. And then another thing that is, again, because the prevalence estimates in the ADDM network reflect those sites that are participating, point out that California, a site in California joined in 2018. You'll see shortly, have the highest prevalence in the network, and that has had an impact on our prevalence estimates since then. All right, so this is prevalence of autism for 1,000 8-year-old children in 2022 across our ADDM network sites. So we see a fair bit of variability. The black horizontal line represents the overall prevalence for all participating ADDM network sites. I've highlighted where Utah is with the red arrow, and then you can see California is all the way on the right with the highest prevalence, which is about about over 5% of 8-year-old children, and Utah is 2.7% of 8-year-old children. Okay. This is what the prevalence of autism among 8-year-old children looks like in Utah across our study years. So on the y-axis, we have the study year starting in 2002 into 2022. This differences in the size of the point estimate itself reflects the underlying population of 8-year-old children that were included. So like in 2002 was the most 8-year-old children, 26,000 children in our 3-county surveillance area. But we're pretty close to that in 2022. It's more like 24,000. So not that different. Do note that this 3-county surveillance area actually contains 50%, about 50% of the 8-year-old population in Utah in any given study year, except for 2008. So again, even in Utah, we've seen an increase over time in the prevalence of autism among 8-year-old children. Okay. And then this figure shows how our children with autism, children are being identified. So this is called an Euler diagram, and it shows the overlap in our three sources, which include the presence of an ICD code, autism special education eligibility, or an autism diagnostic statement. We see about almost 35% of our children have 8-year-old children in the ADDM network have all three sources. So consistency across our ascertainment approach. And then really just like to note the importance of our collaboration with our education partners. Across the network, 67% of 8-year-old children with autism had an autism special education eligibility. And almost 18% of children with autism, that's their only source of identification. So if we didn't partner with education, we wouldn't identify, we'd be missing information about 18% of our autistic 8-year-olds. This figure shows us autism prevalence by race ethnicity, and this is really a pattern that's changed over time. I think I want to say about 8 years ago, we saw the prevalence of autism was significantly higher in our white non-Hispanic children, who are represented in this figure in orange. And that has really flipped now, where the prevalence of autism is actually lowest in white non-Hispanic children, and then higher in children from other race ethnicity groups. So we think this is really the result of improved awareness over time of autism in different children from different race ethnicity groups, and better identification by the community of autism in these children. And this just the same shows us the prevalence of autism in 8-year-old children by race ethnicity by study year. So as I just mentioned, right, with white non-Hispanic children are represented in orange, and see for many years highest prevalence was in that of autism was in that group. And then we started to see this change in about 2016. And then here in Utah, we've seen this change as well, where now the prevalence of autism is highest in our Black non-Hispanic children. And actually 2022 was the first year that we could actually estimate the prevalence of autism in Black non-Hispanic children in Utah. Until that point, we didn't have, that group was too small to accurately estimate the prevalence of autism. So yeah, that there are differences we've seen here in Utah as well. In terms of the distribution of IQ scores and intellectual disability among children aged 8 within the ADDM network, we see overall pretty consistent co-occurring ID, which is represented in yellow, between females and males, about 40% across the network, and then some differences by race ethnicity as well. So a little bit above 50% in Black non-Hispanic children for co-occurring ID, to about 30% in children belonging to 2 or more race ethnicity groups. And then in Utah, among the children who have IQ data available that we found in their health and education records, about 34% had co-occurring intellectual disability. And that is a percentage that has varied across the years, with as low as about 20% of autistic 8-year-olds having co-occurring intellectual disability. And now we're, again, about a third of 8-year-old children. All right. Another area we have seen a change in terms of the prevalence of 8-year-olds is by socioeconomic status. So over on the left, this figure from a paper on the prevalence of autism by tertile of socioeconomic status. So considering the lowest 1/3 background for socioeconomic status in this light blue, this sort of medium blue color represents the medium third socioeconomic status tertile, and this darker blue is the highest. In 2010, we really saw evidence of autism prevalence being higher for those belonging to the highest SES group. That has now really flipped again. So for Utah, we see the highest prevalence of autism in 8-year-old children belonging to the lowest tertile of socioeconomic status, and then the lowest autism prevalence in those belonging to the highest tertile of socioeconomic status. Across the network, it's not quite the same pattern, but we don't see the highest prevalence in the highest SES group. We actually see the highest prevalence in the medium, children belonging to the medium tertile of socioeconomic status. So we have seen changes over time in our understanding of who has been identified with autism over the years. And then finally, I just want to present to you for 8-year-olds the types of diagnostic tests that we're seeing being done in our communities. So this is a busy figure. It shows different autism tests by each site. So let's just focus on Utah. For children identified with autism, we have found evidence of an autism diagnostic test for 66% of our 8-year-old children. Popular tests include ADOS, ASRS. Those are the two most popular, and then we are seeing the use of other tests, including CARS and GARS, SRS, and so forth. So it gives you some insight into the type of tools that are being used in our communities. Let's switch a little bit to see what we, in our understanding of autism among our 4-year-olds in study year 2022. So this is a figure that shows us the overall prevalence of autism among all sites participating in the ADDM network. Again, as we saw for 8-year-olds, we see quite a bit of range in the prevalence of autism in 4-year-olds across ADDM network sites, with the highest prevalence in California, and then Utah's prevalence being on the lower side, with our prevalence among 4-year-olds being about 1.8% of our 4-year-old population in our 3-county surveillance area. Right. And then this is a comparison of the prevalence between 4 and 8-year-olds. In the ADDM network, for the majority of ADDM network sites, we see that the prevalence of 8-year-olds is higher, the prevalence of autism is higher among 8-year-olds, which are represented in blue. And this is what we have been expected, and it's been the pattern for many years now. That's the case for Utah, where the prevalence of autism is a fair bit lower for 4-year-olds and 8-year-olds. However, for some sites, it's actually not the case. Really stands out for Puerto Rico and for California, where the prevalence of autism is higher in their 4-year-olds compared to their 8-year-olds. Again, thinking about where children in the community are being identified in terms of for 4-year-olds, we a little bit different than what we see for 8-year-olds. And of course, this I think has to do with these children being still preschool age and not yet being school age. So we see a little bit less of identification of our 4-year-old children by through education sources, but still 11% of our 4-year-olds are identified solely through a special education eligibility of autism. And overall, about 43% of 4-year-old children with autism had an autism special education eligibility. Okay. For our 4-year-old children, here is a look at how autism prevalence across the ADDM network varies by race, ethnicity. And so similar to 8-year-olds, prevalence is lowest among white, non-Hispanic children, and highest among Hispanic children across the ADDM network. Here, we'll skip that one. And then for the 4-year-olds only, we measured the prevalence of autism if we also include children who are suspected to have autism. And these are figures on the left-hand side. This is the ratio of suspected 4-year-old children to identified 4-year-old children for each site that participated in the ADDM network. And I'm pointing out what that ratio was for Utah, because in Utah in the year 2020, for every child, every 2 children identified with autism, we had 1 child suspected with autism. So that was a 2-to-1 ratio. Now that made us a little bit concerned at the time that 4-year-old children with autism, they were suspected of autism, they weren't quite receiving that diagnosis yet. So that was something that we really noted at the time. And then by 2022, which is on the left-hand side, we've actually seen a real shift in that ratio. So now for every 10 children identified with autism, 4-year-old children identified with autism, we have 1 child suspected of autism. So that to us is an improvement in terms of children who are waiting potentially for an assessment that that we're seeing improvement in these 4-year-old children having access to that. Okay. In terms of the median age of first identification, this is each study year in Utah, or actually this is across the ADDM network, starting the year 2002 through 2016. The median age of identification was 57 months in 2002, and then 54 months in 2016. We're not seeing huge changes in the median age at first identification across the ADDM network. When we look at this information considering median age. However, when we consider the cumulative incidence of autism among our 4-year-olds, so again, this is the rate of being identified, we are seeing differences in over time. So we see a steeper, this top curve is 2016, and this gray curve, the bottom curve, is 2002. The steeper the slope, the faster children are being, is the identification of autism is happening. So we are relieved to see that these slopes are steeper in more recent study years. So that means we actually are improving our identification of children at younger ages. So that's why it's important to kind of look at these different measures from different perspectives. So if we look at Utah at our cumulative incidence in study year 2022 in 4 versus 8-year-olds, we are also seeing, on the right-hand side is the Utah data, in our 8-year-olds represented here in this blue line and our 4-year-olds represented in this orange line, a steeper cumulative incidence curve for our 4-year-olds versus our 8-year-olds. So again, 4-year-olds are being identified at a faster rate and at a little younger ages than the 8-year-olds are. And then that's also consistent with the entire ADDM network, which is shown on the left-hand side of this slide. Okay, so to summarize what were our findings for autism prevalence. Autism prevalence has increased over time since 2002 in the ADDM network. We've seen real improvements in the identification of autism by race, ethnicity, and by socioeconomic status. Schools are a critical source of information on children with autism and remain a critical collaborator for this work. We see a lot of prevalence that varies site to site, and that this variation by site really impacts our overall prevalence estimate. We see, how the inclusion of a site in California and their very high prevalence pulls up the overall prevalence estimate. I just think this is important to understand when we hear this 1 in 31 children statistic. 1 in 31 8-year-old children has autism. We are seeing evidence that children with autism are being identified earlier. I didn't talk much about characteristics of autism in our 16-year-olds, but this is also providing us with critical information, especially related to what is being done to prepare children with autism for transition into adulthood. So that is some of the work that we are doing with our 16-year-olds. And then, really understanding autism in the context of co-occurring conditions and other features related to autism. So, and are continuing our work in that area as well. So now I'd like to talk briefly about some of the work we're doing on early screening, autism screening, and provider referral practices in Utah. And I think this is a study that is probably of interest to all of you today. And this is work really being led by Maddie, our project coordinator for Utah ADDM, and then Dr. Debbie Builder, who is the co-principal investigator of the Utah ADDM project. So I mentioned we're not seeing huge changes in median age of autism identification in Utah. This is what it looks like for 8-year-olds. I presented this data a little bit differently just a few slides back. So why might this be is a question we've had. And at the same time, I talked about how in 2020, we had this ratio of a high number of suspected to identified 4-year-old children with autism. And then, we've also having at the same time in Utah some calls to action within the Intermountain healthcare system. We've had UDAC, I'm sorry, specifically it's UDAC, the Utah Developmental Assessment Clinic, a streamlined diagnostic process. So STAT training for all primary care providers so that it's to help reduce the time it takes, make it more efficient and effective to identify children with autism. The STAT is a faster, more streamlined approach compared to the ADOS. So that was the goal to help, or action to help speed up the time that taken to assess children for autism. And then at the same time, Medicaid recently lifted age limits on broader use of diagnostic tools for autism diagnosis. So hopefully in combo, that would help improve the age at first identification. And then we had conversations with your own Janelle Preston about what information is needed to help inform age at first identification. And she talked to us about the need to study provider referral practices following an at-risk screening result. So that's what we, oh yes, and at the same, just to remind everyone, what is the American Academy of Pediatric Screening and Referral recommendations? Their recommendations are to screen at 18 and 24 months, and plus at all baby well checkups, so really consistent screening, which is something they really emphasized more recently in 2020. The use of validated tools such as the MChat, and a follow-up interview to reduce false positive. And then they recommend after a failed screener, immediate action. Refer concurrently to both early intervention, also a diagnostic evaluation, audiology if that's needed, and so forth, provide support to families, address access issues, cultural barriers, and again, prioritizing earlier intervention in services even before an autism diagnosis can happen. So those are the recommendations that we're working with. Okay, so this is data from 2022. This is information on children, 4-year-old children, so who we could find evidence of a screener present in their records. So again, because the study is cross-sectional, and we're looking at records from 4-year-old children that we can find who are 4 years old in 2022. There may be a screener done outside of Utah, outside of our surveillance area, or to which we don't have access to. But we could find at least one autism screen for 157 4-year-old autistic children. Then we specifically abstracted information from the MChart and the POSI. And then just on the right-hand side, we also abstracted information screeners for our 8-year-olds as well. And this just shows you differences in the frequency and the use of the MChat versus the POSI. So in our younger kiddos, we're seeing more use of the POSI. And I think that's going to continue with additional cohorts in the future as well. We'll see maybe the POSI preferred over the MChat. All right. So here is for these 157 children who we had a screener for. And again, these are all children who have autism. Just want to emphasize that. So they've been identified with autism in the community. 39% of them did not score at risk. And then 61% of our children with autism had at least one at-risk score. Okay. And again, we could abstract for children, they could have had multiple screeners. So we abstracted, we took information from every screener we encountered. And then from this 39% with no at-risk score, 13% of these children were suspected by providers of having autism despite the no risk and referred at that encounter for a diagnostic evaluation. Okay. This is a figure showing you differences at the age at first diagnostic evaluation based on this, the referral practice. So for a child who screened at risk at their first screen, some of them were immediately referred for a diagnosis. And so they had the lowest median age at first autism diagnostic evaluation. Some children referred to EI only, so a little bit of a difference in the age at their first autism diagnostic evaluation. And then for children who scored at risk, but there was no referral that could be found, they had the oldest age at first diagnostic evaluation. So we are seeing differences in referral practices in the community, and that impacts age at first diagnostic evaluation, and it also impacts age at first diagnosis. So for children who screened at risk and were immediately referred, they had the youngest age at first autism diagnosis, and this was significantly younger than the children who screened at risk but did not get referred. So we really see kind of a dose-response relationship here in terms of age at first autism diagnosis, depending on the referral practice. So youngest age for those referred right away to autism diagnosis, a little bit older for referral to early intervention only, and if there was no referral, oldest age at first diagnosis. And so again, returning back to that ratio of suspected to formal autism diagnosis, we have seen improvements between study year 2022, 2020, or between 2020 and 2022. It's a very positive movement, suggests some of that bottleneck being reduced between need for getting formal autism diagnosis and it actually happening. So some take homes from this work. We found that EI referral is not required for diagnosis, or EI referral does not require a diagnosis, and that's, really, and even the EI getting referred to EI is playing an important role in terms of age at first autism diagnosis and evaluation. 10% of children with first at-risk screening result were referred to EI instead of a diagnostic evaluation. And then we are seeing differences in age at first diagnosis and referral between these three different groups. We are putting together, really, Dr. Builder and Maddie are putting together a summary of these findings in a provider bulletin that we'll be happy to share. It is not finalized yet, but please know that that's on its way if it is of interest to you. So that's what I have to share with you today. And before we do a little Q&A discussion, obviously none of this work, this all takes the team. None of this work would have been possible with an amazing URAD team and our partners at the Department of Health and Human Services, and our stakeholders and collaborators here in Utah, which absolutely make this work possible. So with that, I will stop talking. Thank you all for your attention today. And please let me know if you have any questions. We're happy to discuss.
So we will open it up for a few questions, if anybody has any. While we're waiting for people to come unmuted or put it in chat, I just want to say how exciting it is that Utah has started to make some improvements in the 4-year-olds. And I loved hearing that the electronic medical records are making it easier for that immediate referral for early intervention as well as a diagnosis. So I'm so happy about that.
Yeah, we are too. Absolutely. I do see a question in the chat. Yeah, there's a great question. Are there any specific challenges associated with identifying autism in bilingual, multilingual children in Utah? Actually, that's a great question. I know that's some work that is being done in terms of research, actually, done at the Utah Developmental Assessment Clinic, UDAC, which is, over the University of Utah Assessment Clinic, and that actually specifically looked at some barriers to assessment and diagnosis, specifically among Spanish-speaking children and families. And then the challenges come with not having enough providers or people capable or trained to do the assessment that are Spanish-speaking, and the need for translation, and the challenges that come with that piece. So I believe Michelle Villalobos has been leading some of that effort. So she'd be a great person to engage with and ask about that. Perhaps she's joined you.
So she is actually, in our spring, some of our spring sessions, we are actually working on some health disparities around racial ethnicities. So she's going to present, and then Jason Fox from the South Main Clinic and his team are going to talk about some of those challenges and successes that they're having.
Excellent. I'm glad to hear that, Janelle, that she'll be, I think she'll be able to really address that question. Her name was Michelle Villalobos.
Yeah, so Michelle. I'll just call her Michelle because, I struggle with names.
So thanks. Great question. Mm-hmm. Oh, yes. Feeling recent CDC recommendations. So the ADDM network has not, so the question is, do I have feelings on the recent CDC recommendations of specific vitamins for autism? Will you track that in any way? So the CDC has not been pulled in, the ADDM network has not been pulled into any of those conversations or announcements. So we do not have plans at this time to do any of that tracking. It's an interesting question. What we do track is some medications. We have tracked, especially in our 16-year-olds, again, because we're really interested in co-occurring conditions and other outcomes among our autistic 16-year-olds. We are tracking the use of antipsychotics in our 16-year-olds. So we are tracking specific medications when we can find that information in medical records, but as of yet, we have not considered, the sort of beyond those medications.
We'll jump in with a note here that Utah Birth Defects Network does hand out folic acid at their booths. So if you have a question, folate or folic acid or one of the other iterations, that is something they hand out at their email events.
Thanks, Colin.
Thanks, Colin. Jennifer, you have your hand raised if you want to just come off mute.
Yeah, I got to figure this out. I'm familiar with the MChat revised, but what's the posse? I'm assuming it's a screener, but for what age? I work with children with special needs and go into their homes and been doing this for 31 years. And so I'm in Montana. So I'm just curious, what is that? Can you explain that for me?
Yeah, that's a great question. The POSI's actually, and Colin and others, correct me if I get this wrong, it's actually more of a locally developed.
Yeah, so that's a great question, and they are very different. The POSI, it's called the Parents' Observation of Social Interaction. It's another great long name. It's supposed to be shorter than the MChat. So when Dr. Carbone and his other group at UDAC and Intermountain were looking at the MChat, it's 20 questions, which is too many, 20 questions. So they wanted to get one that was even shorter. So like Amanda was saying, they really kind of pioneered using that to get kind of just those core questions. So it's a very short screening tool. Intermountain is pushing that out everywhere, and they have and I've probably changed now, so they switched to Epic, but they have reminders in their EMRs and such to do it. So it's not one in Montana that you would have seen. It's a real local effort here in Utah, led by our friends at UDAC and IHC. But it's meant to be shorter.
Thanks, Jennifer. Question, and my apologies for not explaining that. So this is, yeah, great to know who's attending today, and yeah, you see these differences in local, and that's why I think the diagnostic test information, which is present for both 4 and 8-year-old in our most recent publication with the CDC for the ADDM network that shows what tests are being done where, could be of interest to some of you out there. I know not Montana doesn't participate, unfortunately, in the ADDM network, but still you get insight into the variability across sites.
Well, Amanda, I certainly appreciate your time and contribution to helping us understand the prevalence around autism. I am going to ask Stephanie to speak so I can pin her for everybody. Stephanie Sogla.
I'm right here.
Why can't I still not see you
me.
on my screen? Talk again.
I'm, I don't know. What do you want me to say?
Right there.
Do
I
you want to talk
finally
about how
found
great
you.
you are? Janelle is the best. She
Okay,
knows
so
everything.
Stephanie is going to be, she is our case presentation for the day. So Stephanie, take it away. Did you want me to share or are you going to share?
Yeah, will you share for me? Thank you.
Gosh, did I say that? I would have had it pulled up.
I like to keep you on your toes today.
One second.
So I'll just share a little bit about myself while Janelle's pulling that up. So my background, I have a degree in child development. Most of my experience is in early childhood. I did do some work with some teenagers in a rehab center, but most of my experience is with young kids. I'm going to go on to the next. Oh, so currently I work for up to 3 um, working with kids with if autism or if there's those early indicators or kind of that social emotional development. And so today's case study, working with one of my children that we work with, some of the visits we do. So we do um, monthly home visits for an hour working on their goals and strategies. And we also offer what's called an ABC class. So that's that social attention, social behavior, social communication. And so that class is here on campus, and it's like a preschool that we kind of work on those skills. And I say that because the child with the case study, he does home visits and he also comes to class. And some of the things that kind of want to bring up, they're happening both at class and at home. So this child is 29 months. He's been in our program for almost a year, and he was recently diagnosed with autism. He's mostly with his mom. He stays at mom's at home all day with him. Dad works away from home during the day, comes home every night, and then leaves in the morning. He also has an older sister. Grandparents, aunts, uncles, cousins live kind of in the area, maybe a couple hours away, so they see them every once in a while. And the family is from the Utah, Idaho area. Some other information is that older sister, who is 5, was also diagnosed with autism. And then there's also some other family members who have that diagnosis as well. So a little bit of background on him. So the main area of concern is that he does not like to participate in structured activities and will throw a tantrum when encouraged or prompted to participate. And the tantrums are pretty hard for parents to deal with. Parents do a great job of like implementing strategies of trying everything. They're like, we will try anything. We just want to help our kids. So they're very active in helping their kids. Some of the tantrums, like they include kicking, screaming. He'll throw himself on the floor. He'll kick his shoes off. He'll like drop down to the floor if they try to like pick him up and move him along to the activity. They can last anywhere from a minute to an hour, depending on how persistent parents are in having him participate. And so sometimes, like in class or at home, we'll bring out pictures to kind of help him like make choices. And sometimes they'll bring out the pictures and then he'll just start having a meltdown. So just anytime he's prompted to participate, he has kind of some troubles there. Um, so some of the goals, parents want him to participate in class activities with less meltdowns and tantrums. They also want him to point to pictures, um, or just use more gestures and words to communicate. He is starting to use some words. He does some gestures, but he has a hard time copying. And so mom's like, maybe pictures will help. But at this point, we're just kind of trying anything that'll help him communicate, right? And so again, mom brings out the pictures. He becomes agitated, refuses to participate. He is doing some requesting, like he'll bring like one of those character juice bottles to mom if he wants juice. Otherwise, he's just kind of climbing on the counters, getting into things, looking for what he wants. Any physical prompts like hand over hand, bringing him to things, trigger tantrum. He also prefers to wander around and play by himself. He is starting to tolerate mom playing next to him and touching his toys. But if she does a little too much direction or a little too much play, then he disengages and will kind of wander away. So, again, we've tried that communication, just seeing if he'll be near the pictures, if he's okay touching instead of exchanging, if he'll point, but none of those are kind of really working. We've tried taking breaks and doing emotional regulation and then bringing him back. But once he's regulated and we try to bring him back to the activity, he'll get upset again. So it's just kind of that back and forth that's going on. So my questions, I guess, are what we want to discuss is how can we encourage him to participate when he hates physical prompts and ignores all other prompts or encouragement? What are some ways that we can co-regulate, especially without the binky, while in a class setting? At home, he goes to another room and plays by himself for a little bit, but in class, that's not 100% possible. And then what are some ways to support and encourage parents when their child is having a tantrum? So mom takes it pretty hard when he's having a tantrum, which makes sense. It's really hard to see your kid having a hard time. So just some ways to support and encourage her. So if the child isn't regulating, what can we do to also support mom? That's my spiel. Anything else, Janelle? Can't hear you, Janelle. Janelle, were you saying something? We can't hear you.
Completely, and nobody can hear me on anything. Come on.
I'm sure it was great, but
This is my first rodeo on Zoom. Anyways, we are going to go into breakout questions. So, and then bump Stephanie in between the breakout groups to be able to answer any follow-up questions with her. Colin, your group is taking question number 1. Madison, your group is tackling number 2. And then Stacy, your group is tackling question number 3. So Tori will open those breakout rooms and we will go into there. Are we all back, Tori?
I think so. Sorry, Janelle.
That's okay.
I had my mute on.
I know, so did I. So, okay, we will compile those. So everybody who took notes, if you will email those to the autism echo at aggies.usu.edu email, we will compile those and put those up on our canvas and send them off to Stephanie. Thank you, everybody, for your time and participation in our Echo series today. Our next one is going to be November 26th, same time, same place. And we are having, it's going to be on picky eating. And I'm drawing a blank on her name right this moment. I should have thought about that ahead of time, but she's going to be talking to us about picky eating and the DIR model. I'm going to say it's a Friday and I need to go home since I can't think or do anything today. So thank you all. Enjoy the rest of your day.